Welcome, everyone. We are delighted to have a special guest today join us for our nephrologic podcast. My name is Mani Wase. I'm an interventional nephrologist in Chicago, and my host is.
Hi, I'm Nagai Malla. I'm an interventional nephrologist in Dallas.
We are delighted to have Dr. John Ross, who is a surgeon exemplar of dialysis vascular access. He resides in South Carolina and has set up a very unique one-stop shop for dialysis access in Orangeburg, where I have visited, and many people who are in the audience have as well. And John, maybe you can just tell us briefly a little bit about the center that you've set up and what are the key benefits, and then we're going to get into some questions about some of the surgical aspects.
And thank you for that gracious introduction. Well, the concept was that the dialysis patients, they really are not quite mobile, and we wanted to set up a center where they could come and have everything done. So in Orangeburg, South Carolina, right in the center part of the state, we have 6 operating rooms. We have 2 surgeons. We have an interventional radiologist and 2 interventional nephrologists that work there. And it is truly trying to be, as much as possible, a one-stop. So patients come from afar. We get them from Georgia, North Carolina, sometimes from Florida. So the concept was that the patient would not have to make multiple trips. They make one trip and everything gets done. And by having these different disciplines there, it is tremendous. We do something, it's called collegiality, where the radiologist may call me and say, John, what do we do here? Or I may call him, hey, I need a little help with this central venous system. Or the nephrologist can come in and he can do nephrology stuff sometimes if the patient needs to be dialyzed. So the whole idea was to be truly, truly comprehensive, to do training. We do a lot of that, and do clinical trials. We do a lot of that. So that's kind of from 10,000 feet what it looks like.
John,
Yeah.
I've visited your facility, and the way you have it set up is phenomenal. It definitely sets the standard at what everyone should strive for. And to audience members that are not aware, you can actually go spend a day and see his setup and how things are done. How long have you been doing this, John?
Since 1979. So you can do the math on that. I probably have the dubious distinction of maybe doing as one person more than anybody in the country. And that's because we concentrated on doing this. Surgeons generally don't like to do, at least they didn't like to do AV access. And I found a great joy in doing it. So they started coming, and it turned out to be the love of my life as far as professional.
Well, patients really are delighted to have your center there. I know that you do 15, 20 plus cases a day. And if a declot's not successful, the patient just goes next door and gets their declot done surgically or an intervention done to reestablish a new access. And so it's just fluid and beautiful. So for those of you who want to see what dialysis access could be, should be, John's setup is just extraordinary. Okay, so we're done heralding the center and the lovely setup that you have and the multidisciplinary nature of it. And now we're going to dig into some questions for you as an extremely high volume dialysis access surgeon. We had Dr. Holman, who you know very well, on recently, and we asked him some questions about some of the things that are slight pet peeves of the interventional nephrologist. And now we want to pivot into asking some for you, but also some setup questions.
John, this concept of the fistula stump that we brought up. And when you convert a, let's say, brachiocephalic fistula and you need an interposition graft, irrespective of the reason, let's assume the outflow is fine. Where do you connect the arterial end of that PTFE, and is it to the original fistula or is it to the brachial artery? This has actually generated quite a bit of conversation in the last couple of weeks, online and offline. One of the issues that came up from some surgeons was they said the brachial artery scars down, therefore it is better, more advantageous potentially to connect the PTFE to your segment of cephalic vein. So walk me through it. Let's hear your thoughts on this topic.
Okay, and we go through the assumption, and you set it up very nicely, that we don't really have an outflow issue. We don't have a conduit issue. We have an issue associated with the anastomotic and the perianastomotic area from the previous brachiocephalic anastomosis. So here's the deal on that. I need to know how big it is. I need to know how many times this thing has been declotted. If I see where there's some aneurysmal dilatation, say a little tubular aneurysmal dilatation, and it's only like maybe 6 or 7 millimeters. In other words, it is not dissimilar to the internal diameter of the graft. You can do very simple end-to-end anastomosis. Now, as that proximal part becomes more and more aneurysmal dilated, which means with the graft in place, it's going to clot, isn't it? It's going to clot like any graft. The natural history of it is that of a graft, not that of a fistula. And then we're going to have to evaluate with the maintenance mode for a period of time what is going to be the long-term natural history of what we have. The natural history, as the at least experience, it becomes increasingly more difficult to declot. In that particular case, what I would really like to do is drop down a more proximal brachial artery, or even convert to an upper arm loop, go to the axillary artery. So I would just move that anastomosis upstream to a very comfortable surgical area. Very comfortable. And I think planning here is very important. The residual aneurysmal dilatation that's in the antecubital area, I would take that out as a secondary procedure. We can come back and do that procedure at 2 weeks, 4 weeks, 6 weeks, unless we have some reason that it has to be taken out quicker than that. That's one approach. Another approach is if it is massive and we expect that it is going to be a difficult dissection, which sometimes you see, then indeed I would do the aneurysm, take it off the brachial artery, clean everything up, and then secondarily in 2 to 3 weeks, come back and put a nice new graft in. It's going to be an immediate cannulation graft such that we don't have to have that catheter for too long a period of time. I think total catheter contact time in whatever we do is terribly, terribly important. So we kind of plan around that also, if that makes any sense.
Okay, so if I can summarize what you just said, if the diameter of the existing fistula, the distal portion of the fistula close to the arterial anastomosis of the graft, is small enough, you're willing to actually do a vein graft anastomosis there. But if it's big, you generally would actually proximalize the anastomosis to reduce any of the nonsense that we happen to get into with a dilated access. You just move it up proximally up to the axillary artery or proximal brachial artery and go from there. Does that sound accurate?
That's perfect. You said it better than I did.
You don't hesitate to put in a short-term catheter if you need to for any sort of access revision, or do you always try to do a catheter-free revision and stage it in such a way?
I like catheter-free. I'm a big believer in self-sealing grafts. The fear of the catheter seems to be all the way in the bell-shaped curve from people that have absolutely no fear of the catheter to people like me that fear the catheter a lot because we've seen the tragedies associated with the catheter. So in answer to that question, when possible, I will do what I possibly can do to obviate the use of a catheter.
Yeah. Okay. So, John, let's pivot to another question. So we hear sometimes that some surgeons are reluctant, especially ones that don't have a lot of experience, they're reluctant to put in a hero graft. They think it's kind of silly. They think that they would prefer to do either a first rib resection because they attribute any stenosis in the subclavian vein to a thoracic outlet syndrome like thing with extrinsic compression. And my discussion oftentimes is that you don't know that this is extrinsic compression unless you're doing some adduction-abduction views with angiography. But in most cases, those stenoses originate because catheters have been there for a protracted period of time. You talk all over the country at vascular access meetings. What do you say to surgeons who express a reluctance about hero grafts, who say they clot all the time, who just bring up what some of the unsubstantiated problems are with them and don't want to place them? Because I know you do a fair number of these.
That's a really good question because, first of all, you have to know the indications for it. And the indications for the hero is that you cannot get blood unobstructedly from the arm all the way back to the right atrium heart from either side. Now, if we have an isolated first rib problem, okay, take that. That's not necessarily an indication for a hero if we know that. But you've got to know that. A CT angiogram can give you a pretty good look at that. But indeed, if that is not the problem, and we have a significant issue associated with the superior vena cava on the left innominate, which we can call that now, and on the right side, there is no way that we're going to be able to get blood unobstructed from both sides. Now, when you're going to use the hero, experience speaking here, the hero seems not to work really well with low blood pressures. I like to see blood pressures on the right side somewhere around 120 systolic, and I don't like to see these blood pressures drop to 70 at the end of dialysis. We have a problem because they clot off. Also, from the left side, I actually like to see 130 130, 140. This is a long, rigid tube. Blood likes to go through things that wiggle. None of this wiggles. All of this is a tube, and it has a tendency to clot. We tell every single patient you're going to clot a couple times a year. Sometimes the reason for clotting is just because of the long, rigid tube, I think. Sometimes it's clotted because of where that connector is located, and by moving the arm up and around, you can actually get a kink up where that titanium connector is. So with the appropriate indication and appropriate technique, that's where we get the best outcomes, but still expect to clot a couple times a year. And for God's sake, don't put a balloon in the connector, because the connector can act like a surgical knife, a circular surgical knife. I have seen balloons sheared off there. So just because you see that lumen, it's only 5 millimeters, don't put a Conquest balloon in there. It's going to be a problem. Just thought I'd throw that in.
True. Yes, we've seen that. We've all seen that.
But you see narrowings in that connector also. You see what looks like intramal hyperplasia transition from that graft into that connector.
I think the point, though, isn't don't do an angioplasty, because we do always see it there, but take care and use a small balloon and not go in there with an ultra high pressure balloon. I think that's the key. That is oftentimes where the narrowing is, and that's what makes these relatively easy to declot. But be gentle and have a little fear. Don't go in there bold with a big balloon and think that you're going to do no harm, because it's a very easy thing. I've seen them decoupled before. You've seen that too, John. And then you end up with a lead. Yeah.
I have not seen that. Wow.
Well, actually, the
That's
balloon will also give you a circular transection of the graft, where the graft goes into the connector. So there are multiple reasons not to do balloons there. I don't know if there's any science behind this, but when I see repeated hero clotting, and we really don't know why, at least from a hemodynamic standpoint, and the hero had been working well for a period, a year and a half. And then what we have done in the past is replace the connector with a new segment of graft, because the weakness of it is right at the connection. And that connector, remember, needs to be in a very quiet zone. In other words, it's not in the deltopectoral groove. It must be more proximal to that in the neck. If it's in the deltopectoral groove, that's real bad. That's real bad.
Do you replace the connector, or do you keep the connector and just replace the PTFE?
No, replace the connector. I'll take that whole little section out around the connector and the peri-connector part and replace that. And sometimes if you see that the graft has been cannulated so many times and you're worried about the conduit part, then just replace all that at the same time, and you replace that with an immediate cannulation graft. And now, in fact, that's the easiest way to do it, because you get a whole new cannulation zone. And you look at the connector also to make sure it's in the correct place. Usually when people place them, there's a tendency to place them too laterally. And then you can just shorten the intravascular part or the cardiac part that goes into the heart. You can readjust it the way it needs to be. And sometimes that helps a lot.
Okay, that's a good tip. Thank you. I thought most people were using the same connector and just replacing the PTFE to it.
They may be doing that, but just by experience, I guess, just replace the whole thing. It's so terribly simple procedure to do, and the results seem to be better. And also watch, from the interventionalists involved, be sure you watch the migration of the outflow component. I mean, it will really migrate or it will retract. And if that be the case, you do your angiogram on a clotted hero and you see it's up against the wall down there in the right atrium. Well, it's now a little bit too long, or sometimes they'll retract all the way back. Yeah, and that needs to be replaced.
Yeah. I've seen a few retract, definitely.
Yeah. I've seen them retract when they're lateral. You're exactly right. And the patient moves their arm a lot, and then they end up being malpositioned and they're up in the superior vena cava. It's a problem.
Yeah, one observation is that when a hero clots early on, and you're going to do a percutaneous declot, be very, very, very careful, because there's a tendency in the outflow component to get the giant platelet plug, where you'll see the plug that is the full length. It's not a clot. It's a platelet plug. And if we don't recognize that early on and we declot this and send that platelet plug to the pulmonary artery, this is catastrophic. So what I think needs to be done, just put a Cumpy catheter in, and you go all the way to the end of the outflow component, and you do a pullback angiogram. If you see something that looks like a spiral there, that is the giant platelet plug. And in my opinion, that needs to be taken out as an open surgical procedure. It's quite impressive.
So 2 questions. 1, why couldn't I just take a Fogarty and try to pull it back the entire length of the HERA outflow? And then 2, when you do it surgically, does that mean you go replace the whole intravascular component? You cut down at the IJ, remove the whole thing, and then drop a new one in? Is that what you're doing?
No, 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 no. What we do, we just cut down on the graft like you do a routine open declot procedure, a little transverse incision. Fogarty catheter goes down, and you pull the entire thing out. It's very simple
Okay.
procedure to do.
So you're just using the Fogarty to go pull the whole thing out.
Yeah, yeah, yeah.
I think the only other point to make here is that for the surgeons that don't put a lot of these in, make sure you take the outflow segment out if the graft goes down and you have no intention of replacing that on that side, or if the patient gets a transplant, or for whatever reason the patient discontinues use of that hero graft, the outflow segment needs to be removed because it can be a source for PEs. And I imagine all of us have seen that. John, maybe you can comment on that.
Boy, would I love to comment on that. And we've seen these where heroes have been down for 6 months or 8 months or so, and we're going to pull this thing out. But what we do now is that we get an echocardiogram, sometimes even a transesophageal echocardiogram, and what you will see, the right atrium is full of clot. And with a little bit of trepidation, pulling it out, we may make this clot fly away. That's just my opinion. I've actually seen that happen. So if it's down for a long period of time, we really do an echocardiogram before we pull it.
I've seen at least a couple of patients with massive PEs because this outflow segment has been forgotten after the patient gets transplanted. So really important point to make.
So always do an echo before you pull an extended for any hero, do you think, or only a dysfunctional hero that's been clotted for a long time?
A dysfunctional one, I don't think it shows up quite as much because, we've got some beautiful echocardiograms that actually show this big dangling clot that's right on the end of the outflow component. And of course, we think that's going to fly away. Probably with running blood, I guess it could happen. We could get clot around it. I've seen that before, but I don't think it occurs nearly as often as the defunctionalized hero.
Okay, another question for you, John. For a brachiobasilic fistula, do you have a preference for a 1-stage versus a 2-stage? How do you help us that are strategizing and planning for access, or for new access surgeons that are starting to pick up dialysis practice? How do you recommend they go about doing brachiobasilic fistula?
And I think everybody's got their own opinions on this, and I'll just give you an opinion because I've made lots of mistakes. So if I'm worried about a patient going to get an ischemic hand, I'm going to do a 2-stage procedure because the first stage is a 20-minute procedure. It's over, it's done. I would rather for them to get an ischemic hand on a very quick, easy operation than to have that longer incision or some kind of incision going all the way up the arm. So that's the arterial side. That's one reason for doing it. Number two is that sometimes I think where, particularly in diabetics, this is my feeling, I would like to test the fistula by having blood go through it on a 2-stage procedure and see if the basilic vein pops up in size. Because if it's very compliant, and you've noticed this, many times these veins will pop up and be 6 millimeters, 7 millimeters in a relatively short period of time. I'm talking 2 or 3 weeks. Sometimes they don't. The other problem we get into on a 1st-stage procedure, as an addendum to what you're saying, and I'm going to get around to a 2-stage, is we have tried to do balloon-assisted maturations on a 1st stage before you do the 2nd stage. That is absolutely, the ones I've seen have been almost a disaster. Even though angiographically it looks really good, just like a balloon-assisted maturation should, when we go in there to do the 2nd stage, you've got things that don't even look like veins in there anymore because the vein has been ruptured and we don't really have a good dissection. I just want to throw that in there because I've done that and made a mistake. Other people evidently have done this and done better. I just don't do that anymore. So when I look to see that I have a big vein, the basilic vein is 5 millimeters, 6 millimeters. That patient's getting a fistula, a single stage. If the patient's had a forearm access, maybe a radiocephalic or maybe a forearm loop graft, which kind of works as a 1st stage, then you can certainly go ahead and do a single stage then with ease. That's a very easy operation. On the 1st stage, what we're going to do is get a really good ultrasound to see how the thing is coming along. And if we don't see good things happening in a reasonable period of time, we abandon that, and that patient may end up with a graft. But it's not going to be a protracted period of time where you're waiting 6, 8, 10, 12 weeks for the 1st stage to pop up. In other words, that patient's going to be getting a 2nd stage procedure done if the 1st stage goes well, or the 2nd stage may turn out to be a graft. That's just philosophy. Why? Total catheter contact time. We're just not going to wait a protracted period of time for something that's not developing appropriately. And that's just an algorithm I like.
So if you are planning a 2-stage fistula, if it fails to mature, you would rather convert it to a graft than do a balloon maturation and then do a transposition stage 2?
That's correct. That's correct.
This is why I like talking to you, because I have done balloon maturations on a stage 1 and then send them back for a transposition.
There's an algorithm for everybody, and that has not worked out so well for me because, like I said, when I do the stage 2, this thing doesn't even look like a vein sometimes in there, and it's very difficult. And then those that did respond when I did these early on like this, we almost always got swing segment stenosis, either outflow or inflow, because the vein's been injured so much, I think. And I think that outflow swing segment stenosis, part of that's a technical issue where we pull too tight on the vein. That's a technical problem.
If everything dilates up like you expect, looks great, no steel, you say you're ready for it, 4 weeks, 6 weeks?
I would say 4 weeks, and I'm just saying that's kind of arbitrary. What I'm concerned about is what I have to do with it to transpose it, what has happened to the vein. Because, you look at these BAM procedures very, very carefully. We've got like little microaneurysms all over the place. They're very small, but see, when it's in a contained space, like when we do brachiocephalics or even radiocephalics, it doesn't make any difference because we have supporting tissue. In the dissection of the first stage to the second stage, I'm taking all the supporting tissues down, and that's where the problem comes in. I'd like to hear other people's opinion on that.
Okay, thank you. That's a good insight. I like that one.
John, you mentioned a little bit earlier that you have a certain approach for patients who may be at high risk of Steele syndrome. What's your bedside assessment of patients, and who do you feel has the highest risk of Steele? And then what's your approach for dialysis access once you determine they're at high risk?
Okay, we go through the usual things. The temperature of the hand, I think, is really good. Capillary filling, I think, is okay. The character of the radial pulse, the character of the ulnar pulse, the systolic blood pressure, and I want to make sure they don't have bradycardia, because if the diastolic filling time is too long, you get retrograde flow, you're going to get a Steele. Then I look at the muscle mass, and the ones that really do a lot of problems with Steele are going to be thin females. They have very little forearm muscle mass. Even having great bounding pulses, they tend not to do well because the capillary bed there cannot compete effectively with the fistula or graft. And if I have that situation, say we've got our 82-year-old little lady who weighs 94 pounds, and my index of Steele is very high because of the things I just mentioned, even if the veins were really good for a fistula, if I decide to do a fistula, that's going to be about a 3.5, maybe up to a 4 millimeter anastomosis only. I cannot make a big anastomosis there. And even sometimes when you make the small anastomosis, they still steal. And I have to do something right in the operating room to take it down even more. Now, if I feel that's not going to work, then we're going high in the axilla. Proximalization of inflow. That's not 100%, by the way. That's not 100%. But if I'm going to put a graft in, I need a blood pressure to drive the graft. In other words, if this poor little lady only has a blood pressure of 90 or so, the graft is not typically going to do well in my hands. The fistula is going to do a little bit better, but again, I'm going to have great attention to that arterial anastomosis. If we get the situation whereby we don't have an acute Steele, but 2 weeks later, we start getting that Steele to take place, we only need 450, 500 cc's going through a fistula. We don't need 1,000 or 1,200 for this little lady. We'll start taking this flow down. We'll ban this. We'll go back or close to the anastomosis somewhere and say, okay, let's take this down to 450. She doesn't need a high flow, and sometimes that works really well also. And that's kind of the way you manage this. It's a difficult problem, and you're still going to get a fixed percentage of these folks that are still going to have the problem.
Great. Okay. Thank you.
All right. Thank you for those thoughts, John. I think this is a good place to wrap it up today. Mani, any other closing thoughts or questions?
No, I think we'll keep you in our circuit for questions that come up around surgical issues.
Fantastic. Thank you so much.
No,
Thanks
thank
so
you. We
much.
enjoyed having you.
Thanks so much. Bye.
And thank you so much. I enjoy both of you. Bye-bye.
All right. Until the next episode. Bye.